Well, thank you everyone for coming. It's a big group today, so that's great. Welcome to October, everyone, for our fun. Every year we have a great lab meeting where we get to really look at all the great presentations for a lot of our students that are going to be presenting soon. That's what we'll be doing today. So we'll go ahead and Michelle will get us started with some lab announcements, and then we'll go into our presentations.
Awesome. Can you see my presenter screen or can you just see the outline?
No, you're good.
Okay, nice. Okay, hi everyone. This is our October 2025 lab meeting. I've already began recording. Okay, we have some special presentations today. So after our lab updates, we'll have some poster presentations from our students who are going to the VaSAM conference. The order of presentations today will be Kristen first, then we'll have Meredith, Sarah, Arsheen, Arjun, Vaishnavi, Rohan, Abhi, and Emily. So for some of our published manuscripts, our most recent ones are the inpatient buprenorphine initiation for treatment of opioid use disorder in pregnancy and postpartum that was sent to AJOG. And then we had another one through the characterization of inflammatory and neurofunctional markers in the context of early life stress among a clinical sample of people maintained on buprenorphine for opioid use disorder, which was sent to Brain, Behavior, and Immunity. Our next manuscript was about the psychosocial correlation of insomnia symptoms among women and men receiving buprenorphine treatment for opioid use disorder. And our last one was opioid use disorder, cascade of care among people who experience perinatal incarceration, which was a qualitative study. So we're really proud of all our people who have sent those published manuscripts. Some other manuscripts that are completely in review is the one from resource utilization among racial subgroups in an integrated obstetric addiction clinic. And then our next one was sex-based differences in neurofunctional domains among adults with severe alcohol use disorder. And we should be hearing back from these very soon. So just to go over some of our social media, make sure that you're active there. We have our IV and Recovery Lab social media through Twitter/X. We also have a YouTube channel, which we add our different trainings, webinars, and our lab meetings. So if you ever miss a lab meeting, you can find them recorded here. We also have our LinkedIn as well, and our Instagram. And here are lab leads. We have Arjun, who is responsible for media, which I kind of went through some of our social media just recently. And then we have Dr. Madison Marcus, who is under our regulatory data. We have Amber Green, which is another one of our coordinators. We have James Bacon, who is a community engagement. We have Michelle, the other Michelle, which is one of our interventionists. We also have Dr. Austin Jones, who's a part of regulatory data. We have Nicole Boss, who's also an interventionist and data regulatory management. And then we have myself, who's another coordinator. So I'm going to go through some of our active projects. We have Project SORT, which is investigating the relationship between sleep and opioid use disorder recovery. We have our other Michelle, which is our study lead. Our other study is the registry study, which is tracking clinical outcomes for pregnant and postpartum patients who seek addiction treatment with our OB Motivate clinic. Our recruitment here is complete, but we're still working through that. You see some of our lab members and students, and Amber is the main lead for this study. Michelle and Amber are leading the CBTIO study, which is about adaptation of cognitive behavioral therapy for insomnia, specifically for people with opioid use disorder. This, however, is active recruitment, and we are using SORT data for this study. We have Luborexant 2.0, which our study leads are Dr. Austin Jones and Madison Marcus and Kaylee Swan. This is on medication treatment study, testing the effects of Luborexant on insomnia and impulsivity among people with opioid use disorder. And this also is in active recruitment. We have Suvorexant, which is a phase 3 double-blind randomized controlled trial of Suvorexant versus the placebo on insomnia among people with opioid use disorder. This is currently in the study planning phase, and our study leads are Dr. Austin Jones and Dr. Madison Marcus. We also have Project Castle, which is developing a computerized intervention, that educates pre-medical professionals on substance use disorder and stigma. This is in our pre-testing phase, and our lead RAs are Amber Green and Dr. Madison Marcus and Dr. Austin Jones. Some of our other educational studies, our clinical research curriculum study is still ongoing, and we have those students who submitted abstracts, and they'll be presenting their posters at the upcoming VaSAM conference, and we'll get that first view of those today. We have Dr. Austin Jones and Nicole Boss as our main lead. Our First Steps project, which was previously the Jeffers project, is addressing maternal morbidity and mortality by adapting a patient navigation model for birthing people with substance use disorder. This is being led by James and Nicole. So other updates, our November meeting will be sent via email. You'll get more updates about that. So we look forward to seeing everyone at that November meeting. Now we'll be rolling over into our special presentations. I'll pause here. Dr. Martin, did you have anything else to add before we begin those?
No, I'm excited to see all the presentations and having a really good representation at Virginia ASAM this year.
Nice. Just wanted to go over some presentation etiquette. Please make sure that you hold your questions after each individual presentation. And please remember as we're going through, our first presenter will be Kristen. And Kristen, just let me know if you need anything possibly enlarged. I'll do my best on this end.
Okay, thanks.
You can take over.
Okay. Hi, everybody. My project was on CPS involvement among parents with a dual diagnosis of PTSD and substance use disorder. We know that post-traumatic stress disorder and substance use disorders are highly comorbid, and that the individual literature suggests that these disorders are associated with adverse child mental health outcomes and negative parenting practices, but how these disorders interact to affect these child outcomes and parenting practices together is under-examined. This is particularly relevant among families involved with CPS because 50 to 80% of them are impacted by some sort of substance use disorder. So this study is examining CPS and custody in relation to PTSD in a clinical sample of parents receiving outpatient addiction medicine treatment. We hypothesized that a dual diagnosis of PTSD and a substance use disorder would be more strongly associated with CPS involvement. This was a secondary data analysis of a cross-sectional survey and medical record review from an outpatient addiction medicine clinic in Virginia. Analyses included participants who responded to questions related to custody and CPS status. PTSD was assessed through participant self-report and also medical chart reviews. And the relationship between PTSD status and CPS involvement was examined using a chi-square test of independence. On the slide, I have demographic data broken down below by PTSD status. We had data on 168 participants who were involved in this study looking at PTSD. It was relatively split evenly among sex, and 70% of our participants were African American or Black. Going on to our preliminary analysis, we had 66 participants, and we tested CPS involvement through the question, as a parent, have you ever interacted with Child Protective Services? Among these 66 participants, 24 had PTSD, while 42 did not. 11 patients with PTSD endorsed CPS involvement, while 16 patients without PTSD endorsed CPS involvement. Our results were statistically non-significant. I have the stats written on the slide. From there, we went on to test the degree of CPS involvement by PTSD status through the question, which of the following best describes your involvement with CPS? And the options: CPS removed one or more of my children permanently, temporarily, or CPS investigated me but never removed any of my children. We had data on 27 participants. 11 of these had PTSD, while 16 did not. 9 patients without PTSD and 5 patients with PTSD endorsed investigation but no removal. 3 patients without PTSD and 4 patients with PTSD endorsed temporary removal, and 2 patients without PTSD and 2 patients with PTSD endorsed permanent removal. Once again, these results were statistically non-significant, which may be due to the fact that we had relatively low sample sizes, or our method of screening for PTSD. So as I discussed in the discussion, although these results are non-significant, they highlight the need for more research to understand the dynamics and prevalence of CPS involvement in this understudied population. Like I said, our results may have been altered by low sample size or inadequate measures of PTSD. PTSD is frequently underdocumented and underreported in African American populations and among people with serious mental illness. Ideally, we would have used a measure with high internal consistency like the PCL5. And if we were to redo this study, building it to assess PTSD, and we use the PCL5, we could have analyzed the relationships between specific PTSD symptom clusters and child outcomes and CPS involvement.
Great job, Kristen. Yay. Does anyone have any feedback? I guess it was super clear. I love it, Kristen. I think that I would just say, I like your at the very end, like if we were to do this study again, we would do this. I think that's a great way to end your presentation or your poster pitch at the conference. So I would definitely keep that in. I think that's a great way to go. You may get some questions at the conference because it's going to be a lot of clinicians.
Yep.
About, clinical things related to CPS. And so we can talk offline if you want. Just feel free to email me if you have any questions, just to kind of understand the basics of that, if you have any. So you
Yeah, that sounds great.
confident when people come up to you with maybe some random clinical questions.
Mhm.
Great. Go on to the next one, Michelle. Perfect.
Okay, hi, I'm Meredith. My project was on psychiatric comorbidities and parenting confidence in pregnant people with opioid use disorder. So a little bit of background: pregnant people with an opioid use disorder, there's a high prevalence of comorbid mood and anxiety disorders. And so previous research has shown that parental sense of competency, so how confident you are in your parenting, is linked to better retention of child custody. But we don't know as much about how the comorbid mood disorders might impact parenting related outcomes. So our goal was to look at how the comorbid depression and anxiety affects parenting confidence and coping. So moving on to the methods, it was a secondary analysis using baseline data from the Better study. And our participants were pregnant people with opioid use disorder being treated at the OB Motivate clinic. So using that baseline data, we specifically looked at the PROMIS anxiety and PROMIS depression scales, parenting sense of competence scale. So that measures confidence and satisfaction in parenting. And then also the perinatal coping scale, which measures about how well they're coping with the stress and transitions of pregnancy and postpartum. So we categorize participants into groups. So those with and without depression and those with and without anxiety, and those are based off of the PROMIS anxiety and depression scales. Then we ran independent t-tests to compare these groups on the, I'm going to say PSOC and PCS because they are a mouthful, those outcomes. So then looking at the demographics, we had 29 participants in total. Average age was about 30, gestational age was 24 weeks, and about 60% were stabilized on medication for opioid use disorder for more than a year. So looking at table 2, so our results showed that participants with depression had significantly lower scores on parenting satisfaction and overall parenting sense of competence compared to those without depression. And then for those with anxiety, they showed lower parenting satisfaction and overall parenting sense of competence score. So same as depression, but in addition, had lower postpartum coping scores. So you can see those bar graphs, the one at the bottom in the middle column. You can see that's for the anxiety. They had lower PCS scores. And then when you go to the column on the right, the PCOS, anxiety and depression, for satisfaction and overall scores were lower. So in summary, among people with pregnant people engaged in OUD treatment, comorbid mood disorders like anxiety and depression appear to negatively impact confidence, coping, and satisfaction in parenting. So those, of course, are important factors because they can influence both maternal recovery and child well-being. So our findings highlight the potential positive impact of screening and treatment for psychiatric comorbidities in this population. And then, of course, since this was a secondary analysis with a relatively small sample size, larger studies are needed to confirm and expand on these findings.
Awesome, Meredith. I feel like you have a lot of P's in your presentation.
I know. And
Pregnant.
then PSOC, I keep wanting to say PCOS. I was like,
Yeah, I know. I would have done the same thing. I think it's like pregnant, postpartum. I just said the psychiatric. Oh, wait, is that a P? But I'm just thinking there's a lot of P's in your presentation.
yes, that was a tongue
Hard.
twister.
Any questions or anything people would like clarity on?
I thought it was a really great presentation, Meredith. Thank you for sharing. Um, I had a question about whether these correlations have been seen in populations other than people with opioid use disorder. So, like in just like the general population, have there been studies that looked at anxiety and depression symptoms and how they correlate with parenting satisfaction or senses of competency?
I want to be able to give you an answer. I came across one really cool article, and I can't remember if it was in people with opioid use disorder or not, but that was the one where it was showing the link to parental sense of competency and child custody. But I can't remember if that was opioid use disorder. So I'll look into that for sure.
That's cool. Yeah, I mean, I would hypothesize that these effects that you're seeing expand beyond just people with opioid use disorder too.
Yeah.
So it's a greater, yeah, very cool. But the study may have been done in the general population before. I don't know. So.
Well, great. Did anyone else have any other feedback? Well, I would say, Meredith, I thought you did a really good job, like pointing people to different parts of your poster. So like, look at table 2, and orienting people, because when they come, people are gonna be like talking to you, but you're gonna be talking about your poster. And so it is good to kind of keep them involved, but you're gonna have to point things out because they're not gonna be able to take a step back and look at your whole poster and orient themselves and listen to you. So it is
Yeah.
good. You did a good job kind of in table 2. You see this and see this here. So continue that. Awesome. Cool.
Oh, hey, Meredith, you might want to, I'm just now realizing because she said table 1 and table 2, you might want to just add like if you're doing that, because I do agree it's great, figure 1 and figure 2 to your bar graphs, so that way you can be like figure 1, figure 2, just because like there's not a y-axis like title on there, and I'm sure that's
Okay, yeah.
because of sizes, and you've got the title up the top, so they can read all that. But if you have like the figure, then you could be like less of here, like manually pointing, and like you
Yeah,
could
okay.
explain it through.
Probably sounds better than the bar chart on the right column. So
Thanks, Meredith. I'm gonna let Sarah go if we don't have any other questions. Sarah would like to share her own screen, so.
Thank you so
Yes.
much. I
Mhm.
made a minor mistake, so I had to change it. Okay, give me 1 second. Okay, are you guys able to see?
Yes.
Okay.
Can you put it in full presenter mode? There you go.
Okay, so I looked at insomnia and the relationship between insomnia and recovery capital among patients with opioid use disorder. So obviously we know that sleep disturbances are really common among people with opioid use disorder, and there's been studies that have shown that bad sleep negatively impacts recovery. And this term recovery capital is defined as internal and external resources that individuals with substance use disorder may accumulate throughout their recovery journey that help sustain their recovery, their long-term recovery. And this connection between sleep disturbances and recovery capital has not been explored. So this is what this study is examining. So this was just a secondary analysis of the SWORD study, I would just say a cross-sectional study that assessed sleep and recovery among adults that are receiving buprenorphine at the Motivate Clinic. Our inclusion criteria were males and females between the ages of 18 to 65 that were diagnosed with OUD and were stabilized on buprenorphine for at least 6 weeks. And then our exclusion criteria were just people with psychiatric impairments or language barrier. So the primary outcome measure was recovery capital, which was measured by the Substance Use Recovery Variable Evaluator, short for SURE. And it looked at, like, it had a total score, but it also looked at like different domains of recovery capital, these like internal and external things that we talked about. So we had like substance use, material resources, outlook on life, self-care, and relationships. And then our independent variable was just insomnia severity, which we used the insomnia severity index, and scores 10 and below were used for no insomnia, and then 11 and above were used for insomnia. So these were like the 2 different groups. And then we just did independent sample t-tests to look at differences in these groups. So table 1 just shows the sample demographics. We had a sample size of 129 with a mean age of 40, and it was mostly cisgender, heterosexual white women in the sample. Figure 1 just shows the differences between the total recovery capital scores. And there was a significant difference found between insomnia and no insomnia groups. So the insomnia groups had a lower total recovery capital score as we expected. And then we also just looked at the different subdomains to see if there were any differences between those, and 3 of them were significant: self-care, relationships, and outlook on life. And obviously it's the same thing as before. The insomnia group scored lower in those. So in conclusion, we obviously found that sleep disturbances, sorry, is this in the way? I don't know if it is, sorry if it is. Sleep disturbances were common among people, or were more among people with lower recovery capital scores. And these different domains kind of can help us guide the treatment and recovery for these people. It just highlights how important it is to address sleep disturbances for these patients. And then for the future, I would like to look to see if there's a correlation between the two. And also, I think it would be interesting to look at sex differences. I feel like maybe for women, like for example, the relationships might be different, just because I feel like women might have they're just known for sustaining better relationships. I'm not sure, but I think that would be interesting to look at. And I think that's it.
Great job, Sarah. That was wonderful. It was good. You have interesting findings. So I think that's great. I'll open it up for any feedback or questions people have.
It's not really a question, but it might be something that somebody asks you at the conference. So your group or your population of interest is going to be people with opioid use disorder. But then when you break it down in figure 2, one of those categories is drug. And then the 4 others are more like outlook and more psychological, more like your influence, your spheres of influence that affect that. So there may be somebody who will potentially ask, like, if you're would you or were you shocked, or did it come as a surprise that drug of the subcategory of drug wasn't statistically different between the two versus even though that's in the OUD population? Or is that like something that you could see either being like drug is all the way consistently, it's always high, or is there was no flexibility because just with this population, there's a lot of variability that happens. So that might be something that they want to, or that could be pointed out that they might notify you about.
Okay, thank you. I thought this is just because in the survey it was the questions under the substance use were oh, do you have cravings? How often do you think about it? So I guess I would just say that doesn't have an effect. This
Mhm,
sleep doesn't have an effect on that,
mhm.
maybe.
Yeah.
Thank you.
And I would just say, Sarah, that finding has come up a lot in the sleep SUD research, because historically we've thought that all the sleep problems that these patients have are due to drug use, but as you know in the sample, most of these patients aren't using anything except for nicotine. And so I think that's the interesting. You say, oh, I know this didn't differ between the two groups, and you can give examples of the questions just like you just told
Okay.
Austin. And so I think that's good for people to know, if someone's having sleep problems, don't just think it's because of substance use. There's something else going on, and it is warranted to clinically address their sleep.
Okay, got it.
Yeah.
Thank you.
Yeah.
Okay, I'll stop sharing.
Good job.
Thank you.
Can you see Oh, 1 second. Okay. Can you see the full screen?
Yeah.
So we have Arsheen going next.
Hi, my name's Arsheen. My poster's titled Telemedicine, In-Person Visits, and Treatment Initiation at the OB Motivate Addiction Care Clinic. Just as kind of an introduction, it's known that women with substance use disorders face a lot more barriers to care and experience higher maternal morbidity and mortality compared to those with non-substance use disorders. I was kind of interested in looking at specifically that time period of COVID when a lot of appointments and meeting people became more telemedicine and not as in person, just due to the restrictions. So, looking at changes in those patterns of how they were contacted versus talking about like was it an in-person visit or was it a virtual visit at the time of the substance use disorder treatment. Kind of that pattern is a little bit unclear per recent research. So this study was looking at patient kind of characteristics and treatment receipt by visit modality at specifically new patient visits at the OB Motivate Addiction Care Clinic. So this was a secondary analysis of participants enrolled in the study looking at the time period from March 2020 at the start of the COVID-19 pandemic to March 2022. And when we looked at our chi-square test, we were comparing patient pregnancy status by visit modality and then looking at treatment status, whether that was they initiated treatment, continued treatment, or both. This is table one are my sample demographics. So we looked at race and ethnicity, employment, and pregnancy status. I think this might be my older poster. So I moved pregnancy status to table two, and then added education to table one, in terms of like GED, college, stuff like that. So I think I've updated that, but and then so looking at the results, my first figure is patient status by visit modality. So you can see a majority of the patients in this sample were pregnant and had in-person visits versus virtual visits in that time period. And then the bottom graph looking at treatment status, whether they initiated treatment, continued treatment, or both. And just looking at the chi-squared, I'm going to look at my poster. So a chi-squared test of independence was performed and evaluating kind of first the relationship between the visit modality and if the treatment was started, continued, or both, and the relationship between those variables was at a p-value of 0.462, and then looking at a chi-square test, evaluating the relationship between pregnancy status and the treatment that was started, continued, or both, and then that relationship had a p-value of 0.962. So from kind of those results, it's indicative that there was no significant difference found between kind of in-person and virtual patient outcomes. Overall, those that started their care with OB Motivate, again, we're looking at more of those new patient visits, whether that was in person or kind of a telemedicine platform, were similar across demographic and clinical factors. Almost all patients continuing their substance use disorder treatment regardless of visit modality. We also looked at the different kinds of substance use disorder, ranging from like opioid use, alcohol use, all the way to cannabis use disorder. And then from kind of our results and discussion, there were high rates of kind of treatment initiation and continuation observed across both modalities, being in person and virtual. And this can suggest that telehealth and those kind of options can be a feasible option for expanding access to care for pregnant and parenting patients, just because we know there might be barriers to accessing care. And this can support kind of viability of more flexible care models to reduce barriers to addiction treatment. And I believe that future research is definitely needed to kind of evaluate more long-term outcomes and optimize more of that post-pandemic care delivery in the addiction population.
Great job, Arsheen. It was good to be able to see these data just because, like, oh, I see Margie, like Margie and I work in the clinic. So just to see the numbers is really nice to be able to kind of see that data back. So it was really good to see the positive outcomes for kind of both patient groups, no matter where they got their initial care. Any questions or feedback people have?
I don't have a question, but good job, Arsheen. I just also, yes, you did update. You're not going crazy. This is your old poster. You did update the tables a little bit, and good job reporting the specific chi-square results. I think that was a very positive change you made in the yellow box as well. One thing that I think might be good to just tweak a little bit, similar to the advice Austin gave to Meredith, is for your figures, just labeling them as figure 1 and figure 2, like how you did for your tables 1 and 2, do the same for your graphs. Otherwise, I think everything else looks great. Good job.
Thank you.
Hi, Arsheen. Great presentation. I really enjoyed it. I just had a question. This isn't necessarily like just maybe something you might be asked or just something like I'm curious about. Was there anything that you saw where patients would like come in one modality, like start virtual and then switch to in person, or like if there was any type of like preferential idea of which one they preferred or anything that they thought that would like also affect the longevity of picking one over the other?
Um, Honestly, I didn't necessarily look at like if they started virtual, did they become in person, but I did notice kind of a trend, just like when I was looking through those charts, like if someone was virtual, their appointment would be like maybe a couple months later, and then at that point it would be like an in-person visit, and I don't think it necessarily changed their treatment course or anything like that, but I think most of them would become like in person a little bit later. It might just be like a timing thing with kind of quarantine and things like that. But yeah, I guess not necessarily. Yeah.
Hi, Arsheen. I'm Margie. I'm one of the nurses in the clinic. Thank you so much for putting all this data together in such a lovely format for everybody to be able to just clearly see what went on. One thing I will have to say in that regard to the last question was the majority of the patients were pregnant. And so, of course, even during COVID, there were times that the patients needed to come in person. So we were still having them. It was scaled down somewhat from your normal recommendations for pregnancy and in-person appointments for labs and ultrasounds and things like that for baby. So we did have that, and then we also are still following federal guidelines on treating persons with an opioid use disorder and how often that we needed to screen them in person with urine screens and things like that, just to make sure that they were getting their medications and taking them. So we were still having people come in that regard, but it was new to do anything over telehealth. So it was kind of a rocky period, and it worked out. I'm really glad to see the data. So thanks so much.
Thank you.
Awesome job, Arsheen.
Thank you.
Hi everyone, my name is Arjun and I'll be presenting my project entitled Cannabis Use Disorder During Pregnancy, Treatment Outcomes in a Perinatal SCD Clinic. So cannabis use disorder is becoming more prevalent among pregnant women, with a 250% increase in diagnoses from 2010 to 2018. And with the recent legalization of marijuana in the past 7 years, this rate could potentially be higher. And already we know that recreational cannabis use has been associated with adverse birth outcomes, anxiety, and depression. However, there is a lack of knowledge about what birthing and care outcomes look like for women with cannabis use disorder, which is characterized by frequent use of cannabis compared to controlled low-risk consumption. And after looking at the literature, I began to wonder what the care trajectory for women with cannabis use disorders looked like as they navigated pregnancy in an integrated perinatal SUD clinic. So, in order to answer this question, I performed a retrospective medical review of birthing people with substance use disorders receiving care from the OB Motivate clinic. And after narrowing our sample to women with cannabis use disorders that were engaged with OB Motivate throughout gestation, I found 9 individuals to include in the case series. So this case series will describe demographic and clinical variables, as well as treatment and delivery outcomes throughout pregnancy. And some important characteristics of our sample that I'd like to highlight in the first table below is how a majority of our sample is white. All participants in our sample are on Medicaid, and 78% of our sample has depression. In terms of birthing outcomes for those in our sample with cannabis use disorder, the mean gestational age was 38.5 weeks, which, according to the American College of Obstetricians and Gynecologists, approaches the normal range for gestational age, which is 39 weeks. In terms of neonatal outcomes, the mean birth weight for a baby born to a mother with cannabis use disorder was around 2,700 grams, and the mean admission rate was 4.75 days for newborns. The birth weight was in normal range according to ACOG guidelines, but the hospital stay length was slightly elevated when compared to guidelines set in place by the American Academy of Pediatrics. In terms of treatment outcomes, I believe it's imperative to note how 2/3 of our sample have co-occurring opioid use disorders, and 44% of our sample has a co-occurring cocaine use disorder as well. And during pregnancy, over 77% of our sample have started or continued an SCD medication throughout gestation. However, we recognized how 6 to 9 months postpartum, urine drug tests indicate that around 55% of our patients had a negative urine drug screen for non-prescribed substances. Additionally, only 1/3 of our patients access behavioral therapy throughout gestation. With this in mind, our case series doesn't necessarily indicate adverse birthing outcomes for those with cannabis use disorder, although extended length of admission for newborns have been noted. We also recognized how initiation of substance use disorders medication for those were high. However, long-term sobriety remained relatively low within the sample. Additionally, when it came to accessing behavioral health treatment, which is currently the mainstay form of treatment for cannabis use disorder, a very low number of patients accessed such services. So, with the low rate of long-term sobriety and behavioral health care utilization, future studies with a larger sample size, of course, should examine facilitators and barriers to engaging in comprehensive perinatal and substance use care for those with cannabis use disorder.
Great job, Arjun. That was really good. I like how you presented your results in context of other general population findings. You might get questions on the neonatal length of stay. It's probably related to a lot of these patients who are on methadone or buprenorphine for opioid use disorder. So if people ask you, you can say that's probably what it is, and we require
Okay.
that those babies stay in the hospital longer to be monitored for NAS. And then I would say that 55% of the people who had the negative drug testing, that's actually really good
Okay.
for SUD treatment studies, because that's actually a pretty good rate compared to other studies. Yeah, because it's actually usually about 60% of people in the course, if you're looking at 6 to 12 months of SUD treatment, depending on the sample, of course, and they drop out of treatment or return to use, et cetera. So having more than half of patients be engaged in treatment and have negative urine drug tests, that's like, I'll take that as a win for the clinic.
Great. Thank you.
Yeah. Any other feedback people have?
I had a clarifying question. So in this clinic in OB Motivate, do you guys see patients with CUD who also have other comorbid SUDs, and were those included in this study, or is it more that this was just specifically CUD and CUD alone?
Yeah, I guess specifically for this review, we focused on those with cannabis use disorders, but I think a majority of patients, and like at least from what I've seen in like the raw data, each patient had a comorbid SCD alongside their cannabis use disorder. Yeah.
Hey Arjun, can you see me?
Hi, yeah.
Yeah, so I was wondering, do you have the number for the percentage of people who reported CUD before like 2010? Like it says there's a 250% increase, but what's the difference in those numbers?
Yeah, that's a great question. I think I forgot which source. I think it was either Dr. Kelly Youngwolf or another, like I think it was from, I think it was published pretty recently, an article in like 2025. I'll try to find it. But the rate was relatively very low because cannabis use disorder, there isn't very like clear-cut criteria for what constitutes cannabis use disorder. So other like pieces of literature kind of indicate that it's typically underdiagnosed. So I know the number isn't like very high, but it has been noted that there has been an increase in diagnoses of cannabis use disorder, especially among pregnant women in recent years. Yeah,
Awesome job.
thank you.
Okay, all right. Can everybody hear me?
Yes.
Okay, perfect. My name is Vaishnavi, and today I am presenting the project Health, Quality of Life, and Insomnia Among Individuals with Opioid Use Disorder. So, as we know, the opioid crisis has been declared as one of the largest public health issues in the United States, leading to morbidity, mortality, and a significant socioeconomic impact. And medications for opioid use disorders, specifically looking at buprenorphine, have been affecting in reducing overdose risk in people who have opioid use disorder. However, we have seen that health disparities exist among people receiving medication for opioid use disorder. And one such health disparity are sleep disturbances such as insomnia that are common for people receiving MOUD, and these can negatively impact their quality of life and their overall health. Additionally, the role that sex differences play in these relationships hasn't been well understood either. So in this study, we aim to look at the sex differences in insomnia, quality of life, and patient-reported health statuses among individuals who are currently receiving buprenorphine for their opioid use disorder. So this is a secondary analysis of the cross-sectional study, which was the sleep and opioid use disorder recovery and treatment study, which is the SORT study. And these participants are essentially adults who are stabilized on buprenorphine and were recruited from an outpatient medical clinic between 2022 and 2023. So the data that was collected, we compared men and women with and without insomnia on several measures, and these measures included the PROMIS 10 health-related quality of life scale, which included the subsections of mental and physical health, and the World Health Organization quality of life scale that was just a Likert scale, as well as demographic data about that. So we did one-way ANOVAs and post-hoc Tukey tests to basically compare men and women with and without insomnia on the quality of life scale and PROMIS 10. And so if you look to your bottom left, that's the demographics. There was 129 participants, with the majority being women and the majority being white. And if you also look at the prevalence of insomnia in this, it's more than 50%. So we are already seeing that many of these participants do have insomnia, which is a score of greater than 11 on the Insomnia Severity Index. And the average that these participants were receiving buprenorphine is 2.52 years. So if you look in the middle with the results, essentially looking at our one-way ANOVA test, we saw that insomnia was associated with worse outcomes in both men and women. So on the PROMIS mental health and physical health scales, as well as the WHO quality of life scales, individuals with insomnia had significantly lower scores than those without insomnias. And specifically, when we looked at sex differences, so looking at the PROMIS 10 mean scores, we can see that there's a women without insomnia have a significantly greater score on the PROMIS health scale than men with insomnia and women with insomnia. And then when we look at it in the subsections of physical health, that same trend remains. And with mental health specifically, we see that women without insomnia have a much greater mental health score than those than women with insomnia. And then when we look at the WHO quality of life scale, we see that women without insomnia have a greater quality of life rating than men with insomnia. So what does this mean? Among people receiving buprenorphine for opioid use disorder, insomnia was seen to have poorer quality of life and health outcomes, especially among women. And these findings essentially highlight the need for sex-specific approaches to addressing sleep disturbances. And while these associations were evident in both men and women, women with insomnia showed particularly reduced PROMIS 10 health scores compared to women without insomnia, suggesting a disproportionate effect. And so since sleep problems may also affect treatment retention and recovery, targeting insomnia could help improve both health outcomes and quality of life in individuals with OUD and currently on medication for their OUD. So in summary, addressing sleep health specifically with a sex-informed perspective could be a valuable strategy in supporting recovery and overall well-being in people who are receiving medication for opioid use disorder and can help health outcomes and quality of life in this population. Thank you.
Great job. Your findings are interesting. One recommendation I would have just when you're presenting it to people is just orienting people to the ranges, for these, because these measures are all a little confusing. Like they always, the way that they're scored and all that. You don't have to go through all the details, but just orienting people to what the ranges of these are so people can understand a little, just a general aspect. Is this a high or low score? Just because I get confused sometimes on these too, and I use them all the time. So great job.
Thank you. Sounds good. I'll do that.
Yeah. Any other feedback or questions people have?
All right. Hi everyone, I'm Rohan, and my study was a narrative review of the risk factors that are present for postpartum MOUD discontinuation. This
Ron, can
was,
I interrupt you for a second? I'm sorry.
oh, sorry.
No, you're good. I'm sorry to interrupt. I just was monitoring the chat and Emily does have to leave early, so I was hoping that we could switch up the order just a bit and have Emily present next, if that's okay. If it's easier, Emily, you can share your screen. Just so everybody presents today. Is that okay, Rohan?
That's fine with me, that's fine with me.
All
Very
right,
sorry
thank
to
you so
cut in
much for being,
line.
yeah. No, you're okay. Thank you so much for being flexible, Rohan.
Of course.
All right, so hello everyone. My name is Emily, and this is my project on pain and insomnia severity in patients with opioid use disorder. So, as we know, any form of disordered sleep can have negative impacts on quality of life, and many people with opioid use disorder also have sleep issues. And in addition to that, we know that chronic pain is correlated with insomnia, and sleep interventions in populations with opioid use disorder can improve treatment outcomes. With that said, there is a lack of understanding for how the intensity, frequency, and the location of pain are related to sleep in among people with opioid use disorder. So for my methods, this was a secondary analysis of the sleep in opioid use disorder recovery and treatment study, which is the SORT study. And the participants were adults stabilized on buprenorphine and recruited from an addiction medicine clinic between 2022 and 2023. And we collected data on demographics, pain intensity, location of pain, and insomnia severity. And as you can see in my demographics table on the bottom left, we took race and ethnicity, sex, and some other things such as average age and mean duration of buprenorphine receipt, which was about 2.5 years for our participants. And then looking in the middle top, you can see t-tests for comparisons of insomnia and pain by sex. So interestingly, here we found that women had significantly higher average scores on the insomnia severity index. And then as for location of pain, most frequently participants had pain in the back and legs. And then on the right, you can see a correlation table looking at pain, sex, and insomnia. And here we found a significant association between chronic pain intensity and insomnia severity. And then additionally, a significant association between insomnia severity and female sex. And then further in a hierarchical linear regression, we found that same significant relationship between intensity of pain and increased insomnia severity, even when we controlled for age, race, and sex. Additionally, finding that location and frequency of pain were not significant. So in conclusion, patients with opioid use disorder may have their sleep disrupted by chronic pain, and reducing intensity of this pain could improve sleep and then consequently treatment outcomes. And in the future, interventions targeting chronic pain in these patients with opioid use disorder should be examined. Thank you.
Great job, Emily. I really like your figure in the middle. I think that's going to draw a lot of people to your poster.
Thank you.
Yeah. Any feedback or questions people have? Okay, clear. Super clear. Great job, Emily. I think it'll be really interesting. People will be interested in your findings, especially the clinical audience, I think.
Thank you. And thank you, Rohan, for being flexible. I'm sorry to hop in front of you and disrupt your presentation.
Don't worry about it. Great job.
Thank you. And great job to everyone else for those of you who I may not be able to see. Thank you.
All right, back to me. Okay. Hi everyone again. I'm Rohan. I'm going to be presenting this little narrative review that is still ongoing that I'm leading on risk factors for postpartum MUD discontinuation. The pregnancy and postpartum period is a time of risk for patients with opioid use disorder. Many patients actually begin receiving MOUD for the first time during this period, but early discontinuation of MOUD is a major challenge for them. Clinical decision-making standards on this sort of period and how to limit postpartum MOUD early discontinuation are still unclear. And so this study is intended to clarify some of the risk factors for postpartum MOUD discontinuation and try to identify some of the reproducible factors that could be further analyzed for MOUD discontinuation and potentially developed as a part of some sort of clinical decision support model. The methods for this study included basically a structured literature search across multiple databases based on the search criteria simply postpartum MOUD discontinuation. Studies were screened from 2015 to 2025 to ensure recency, and the entire process was done through Covidence using an unstructured extraction format. Inclusion and exclusion criteria for studies were based on a two-stage title and abstract and then full text screening. Some of them are listed here. They had to be randomized controlled trials. Patients had to include only patients who were either pregnant all the way to a maximum of 1 year postpartum. They had to include 3 months or more of postpartum MOUD metrics that included some form of discontinuation metrics. And then In this study, we excluded incarceration and any patients that were incarcerated, specifically due to the unique landscape of MOUD availability, adherence, and some of the socioeconomic factors that play into that situation that are different from non-incarcerated patients who are receiving MOUD. So figure 1 shows the Prisma graph for our narrative review, sort of showing how the amount of studies we got and how we narrowed them down. We started with about 58, I believe, studies that we were able to identify and screen as non-duplicate across all of the databases that we searched. And then slowly through filtration and two-stage screening based on the inclusion-exclusion criteria, 14 were identified and retrieved successfully for this analysis. Figure 2 shows the very preliminary, basically just identified risk factors that had showed statistical significance across all the studies that were extracted. And you can see here that the 2 most consistently identified and reproducible risk factors were A, non-white status of the patient, and then the second was late initiation in the 3rd trimester of pregnancy or in the postpartum period. There was one interesting risk factor that I found as well. That was use of buprenorphine or giving patients buprenorphine as opposed to methadone. 2 studies found that buprenorphine initiation was associated with an increased risk of discontinuation, while 2 other studies actually found that it was a decreased risk or a protective factor. I'm not quite sure why this is. One confounding effect that could be happening is that buprenorphine is relatively highly prescribed to white populations rather than non-white populations. And so that sort of white versus non-white status could be a confounding effect in why buprenorphine initiation showed this sort of effect across multiple studies. But I wasn't really sure where else or why that occurs, and that might be a topic for future research analysis to clarify the sort of standing of what's going on there. Future analysis could also be done just specifically on comparing how all of these risk factors work together and meld together to create a clear clinical decision support model for what's going on with postpartum MOUD discontinuation, what providers should look for in determining risk. Some limitations of the study include that the study, as a narrative review so far, does not directly compare the strength of association between risk factors and MOED discontinuation, and they focus specifically on studies from 2015 to 2025, may exclude some studies that have shown reproducibility but were excluded due to this arbitrary date range. And my references are below. You can also see, I can post the link for the references. It's at the bottom, but it's like 6-point font because of the size, but to all the studies that were screened and identified in this paper.
Great job, Rohan. I think it was really good for you to show kind of how the review process works. And that was, in your methods, because that's kind of the unique part of this. So I like that. Any other questions or clarifications people have?
Rohan, when you said like race could be a confounding variable to why buprenorphine was a risk factor, like what do you think is going on there? Like what? I don't know.
Yeah, to be honest, I'm perplexed too.
Yeah.
I think when it comes to buprenorphine being a protective risk factor, that would align better with what I saw in the study because buprenorphine, of course, is prescribed more often to white populations than non-white populations, and this is something that's also in pregnant patients as well. And in this case, and that non-white status was a identified risk factor with significance across multiple studies.
Okay.
I'm
I
not
see.
quite sure why buprenorphine would also be a risk factor or shown as a risk factor in some of these studies.
Hmm.
So that's something that I'd like to see further research on because that's something that I wasn't able to explain.
Thanks.
Super interesting, Rohan. I was just curious how you kind of identified your inclusion and exclusion criteria. Like what went through your head when choosing the criteria for all of the different articles and stuff like that, different studies?
Yeah, I can talk to them a little more like deeply. The first thing was that Scoping reviews and narrative reviews have been done on this topic before, and this was sort of following in line with some of their inclusion exclusion criteria. The longer answer is that having randomized control trials and cohort studies is just good for narrative reviews. You don't want to be reviewing reviews and sort of meta-analyzing the meta-analysis. It gets a little messy there. So that's where that came from. And then exclusion of patients past 1 year postpartum or like non-pregnant patients, I thought would induce like confounding variables past that 1 year postpartum where there's other factors that are also at play. And then metrics for MOUD discontinuation more than 3 months postpartum was simply because it's a postpartum MOUD discontinuation risk. Discontinuation's more common in the postpartum period, and less common in the pregnancy period. Like once people have delivered, that's when they're lost to follow up more consistently. And anyone who has clinical experience can speak more to that part because I'm just a researcher here.
Very cool. Thanks.
For time, we still have one more, correct, Michelle? Yeah. And Rohan, I'm happy to talk to you offline about your findings and give you some context.
That'd be amazing. Thanks so much, Dr. Martin.
Yeah.
Hello, everyone. I'm Abhirami, and my project is an analysis of breastfeeding rates at discharge among integrated OBGYN addiction care program patients. So for a little bit of background, substance use disorders are becoming increasingly more common among pregnant individuals. Research has shown that breastfeeding offers significant benefits for the mother-infant pair, such as reduced infection risk and stronger bonding. However, despite these benefits, breastfeeding rates are often low among women with the SUD diagnosis upon hospital discharge. So my study aims to describe and assess breastfeeding rates among postpartum women with a documented SUD diagnosis at the OB Motivate clinic in relation to various clinical variables such as sample demographics, including age, race, education, and employment, presence of a documented psychiatric comorbidity, if any, and receipt of a lactation consultation. My study is a secondary analysis of a retrospective medical record review of pregnant and postpartum patients receiving care at OB Motivate Clinic and who consented to be part of the OB Motivate research registry. My population consisted of postpartum female patients aged 19 to 44 with a documented SUD diagnosis and who delivered a live infant from 2021 to 2022. We had a total sample size of 48 participants, and I used chi-square tests to compare breastfeeding rates at hospital discharge among the various clinical variables that I mentioned earlier. Now to go over some of the key results. So overall, 58.3% of the participants were breastfeeding at the time of hospital discharge. When discussing demographic variables, which is the first 4 bar graphs, the highest proportion of patients who were breastfeeding were within the 19 to 29 age range. Caucasian patients were the highest number of patients breastfeeding at hospital discharge. The highest number of patients who were breastfeeding at discharge had a high school diploma or GED as the highest level of education completed. And employed patients, in comparison with unemployed, showed a much higher rate of breastfeeding compared to those who did not. Moving on to the presence of psychiatric comorbidity, which is the graph at the bottom left, almost the entire sample population had a documented comorbid psychiatric condition. So there was no significant difference in breastfeeding rates based on the presence of a psychiatric comorbidity. Moving on to the receipt of a lactation consultation, which is the bottom right bar graph. A majority of the patients did not receive a lactation consult, around 56.3% of them. And there was no significant difference in breastfeeding rates between those who received a consult versus those who did not. Lastly, in regards to the presence of a polysubstance use disorder versus not, Breastfeeding rates were similar for patients with one versus polysubstance use disorder, so there was no difference amongst the rates in both those populations. In conclusion, it is clear that this patient population has complex needs, and this reinforces the critical role of a comprehensive, multidisciplinary care model in supporting these patients, and particularly the mother-infant dyad. In regards to next steps and future directions for this project, further studies can be conducted with larger population sizes to warrant a better examination of the patterns of breastfeeding rates among women with SUDs. The information obtained from such studies can then be used to inform the development and implementation of lactation consultation services and prenatal care tailored to the specific needs of pregnant people with SUD. Thank you.
Great job, Avi. That was great. It's so good to see this data and just kind of how the patients are looking by this, because this is something sometimes we don't get because we see them in the clinic and then we see them again in the clinic, but we don't follow them, every day and through the clinic staff, I mean. So it's great to be able to kind of see the trajectories of these patients. I think you do a really good job with your presentation, just being very clear with the point of the study and with your findings. So awesome job.
Thank you.
I have to head out to another meeting, but Nicole's going to take over moderating any final feedback and housekeeping for you guys. But great job.
Hi, everyone. Does anybody have questions or feedback for Abby?
I had one thing to consider, and maybe you know this, and I really don't know, but when the lactation consultants go in to talk with the patients, can the patients decline, like, oh, everything's fine? I'm just kind of curious if there, was everybody offered? That's what I really want to know. Were they all offered that consult, or was it, or are you finding they weren't even offered the consult half the time or whatever?
That's a great question. So I used the OB Motivate registry data and the form, which essentially just had variables documented for yes, they had a consult versus no, they didn't. So I do not know if everyone was offered a consult and versus was the yes or no just based on like patient preference saying, no, I don't want it? Or was it like there were barriers? Did they not come up for a follow-up? Were they not there in the meetings? Did they miss the meeting? So I don't know that yet, but I will work with Amber and clarify that before I go present at the conference.
I can clarify a little bit more, but great question, Margie. Thanks. We did in the data set that Abby's referring to, we look across both prepartum, at delivery, and postpartum as well. So we looked across 3 different time points. Though Abby is right in the distinction that there's only the binary yes no whether or not where how we're tracking the data, whether basically if they got the consult or not. And when we're looking through Epic, sometimes it's if it's just not even listed at all, we just assume that no, the patient didn't receive the consult at that time. But her results do incorporate across prepartum and at delivery as well as postpartum as well. So as long as the participant either did receive a lactation consult, it could have been at any point during those 3 time periods.
Yeah. You have me wanting to ask how that works on the unit side too. Because I'm assuming a patient can decline.
Oh, 100%. And I think you and Dr. Martin and the whole OB team would know much better than we would, because we're only working with what we can see through Epic. So sometimes it's just maybe it might be hard for us to really find the answer through Epic if it's there, if it's super hidden in a note or something. There is the possibility. It is a limitation too, where it's just where we didn't look hard enough or we just missed it or something. But yeah, that's a good point. That's a good question.
But otherwise, no, thank you so much for even looking at it, because like you said, it's so important, the breastfeeding and even the duration. And I would probably to start even say, I like you said, very important for bonding. We know that's very important for infections, lowering the risk for infection for baby. But also, you've got this on women with OUD or SUD, and we know that it's also very good for lowering symptoms of neonatal abstinence syndrome. So they're less likely to, need pharmacological, care if they're receiving breast milk. So it's kind of it's highly recommended in this population. It's
Yeah,
really
that's
cool.
what. Yeah, I think that's what even prompted me to look into it, because in my initial review, these benefits were coming up, but it wasn't translating into the rates that were showing up. And I think it's very helpful getting your insight as well on the clinic side as well.
Anybody else before we go to like some administrative stuff? No? Okay, so I tried to be quiet today because you guys have dealt with so much feedback from me that I was like, let's have some other people provide some feedback. Uh, so first of all, you should be so